everyone, and welcome to today's Connect and Learn webinar. I'd like to begin by acknowledging the traditional custodians on the land on which this is being presented and recorded, the Wurundjeri people of the Kulin Nation. I would like to pay my respects to them, to elders past, present and emerging, and extend that respect to any First Nation people who are listening today or in the future. My name is Dr. Annie Hinemawana, and I work at Monash/Turning Point in the Masters of Addiction. So I'm a lecturer in that course. Today's presentation is part of a series of Connect and Learn webinars, and they're designed to support Aod clinicians throughout Victoria. And this webinar series is funded by the Victorian Department of Health, and it's hosted by Turning Point. We like our webinars to be as interactive as possible, so please ask questions via the Q&A button, which you'll find down at the bottom of your page. And the questions will be collated and answered by the presenters at the end. And please be also aware that this is being recorded and it will be available for you to watch again on the Turning Point website. We encourage you, if you can, to stay to the end of the presentation and complete the exit survey when the QR code appears. And it will come on via a slide or an email later today. A copy of the slides will also be emailed to you. So today, it's my great pleasure to introduce our presenter, Dr. Vicky Phan. Vicky is an addiction psychiatrist working at Turning Point, Eastern Treatment Services, and she's also a lecturer in the Masters of Addictive Behaviours course at Monash University at Turning Point. She's completed specialist medical training in addiction psychiatry, and she has postgraduate qualifications in psychiatry, public health, and alcohol and other drugs. Vicky has a great deal of experience working across Aod and mental health services in both New South Wales and Victoria, and she believes in a holistic and person-centred approach when working with people and their families. Her areas of special interest include mental health comorbidity, harm minimisation, pharmacotherapy, and training and education. So I'll pass it over now to Vicky.
Great. Thanks, Annie, and thanks everyone for coming along today to this Connect and Learn. Just to introduce the topic that I'll be presenting on, today is smoking cessation, tobacco harms, vaping and clinician attitudes. And part of why I've chosen this topic is because smoking is still very relevant to our work in the Aod sector, and there have been some changes to the legislation around vaping as of October last year implemented by the TGA. So it's probably worth doing a bit of an update on this space. Thanks to Annie for her very nice introduction. As you can see in my bio, I'm an addiction psychiatrist currently working at Turning Point Eastern Treatment Services, and I'm also a lecturer from Monash University. So in this talk, we're going to cover a couple of things, and this slide will cover the outline of this talk. So we're going to start by looking at tobacco and nicotine. Then we're going to explore the prevalence of smoking in Australia, go on to the burden of smoking so we can understand why this is a relevant health issue, deep dive into tobacco smoking in Aod populations, because this is the work environment that we're seeing people in. And then we will also go into our clinician responses to smoking, and finally wrap up with the smoking cessation strategies we've got available in Australia, including vaping and harm reduction. So to start off with, I just want to go through what tobacco and nicotine are. So of course, tobacco is a plant which contains nicotine. Tobacco is a common name for several plants in the Nicotiana genus. There are more than 70 species of tobacco that are known. The main commercial crop we have is Nicotiana tabacum, which is that image in the top right there. And it's the highly addictive stimulant alkaloid nicotine inside the tobacco that we worry about clinically. So why do we worry about nicotine? It's not the most toxic substance in cigarettes. It's the most addictive one. So this is what keeps our clients and patients hooked. And causes things like a nicotine tobacco use disorder to develop. But interestingly, it's the other 7,000 toxins and chemicals in tobacco which are actually the most harmful, in particular tar and carbon monoxide. So many of you would have seen the ads back in the day of beakers of tar being poured out to symbolise what goes into the lungs. So that tar is a sticky brown substance which accumulates in our lungs and causes lots of health damage. And carbon monoxide is a clear odorless gas which binds to our red blood cells, which typically carry oxygen around, and that impairs the ability of our body to deliver oxygen around the body, and that can cause a bunch of issues as well. So it's not just the nicotine we worry about, even though that's the one that we know gets people addicted. We also worry about these other 7,000 toxins, in particular things like tar and carbon monoxide. And the other concern we have is that there's at least around 70 known cancer-causing agents in tobacco smoke that have now been identified as well. So going into the types of tobacco products that we might see, examples of tobacco products are shown in this slide here. So on the left hand, we've got cigarettes at the top, we've got our cigars and cigarillos, we've got our pipe, we've got our rollies. So when people roll their own tobacco into papers with filters, we've got our kind of shisha hookah use tobacco in the bottom left there. And then in the right side, we've got a couple of interesting ones, which I'll get to in a sec. So tobacco products are essentially made from the leaves of the tobacco plant that I showed you earlier. These leaves get dried out or cured. They then get fermented by being stacked on each other and allowing the humidity process to ferment them. And then they get aged before they get manufactured into tobacco products. There's tight laws that control tobacco manufacturing, marketing, distribution and use, and how the tobacco is prepared is done differently depending on how people will consume the tobacco. So in cigarettes, we see the tobacco leaf being finely cut up and rolled in thin paper. In cigars, people will purchase whole tobacco leaves, which they then put in the pipe. In a hookah, you'll get the flavoured and sweetened tobacco that is heated, and then the smoke filters through the water in that device and then into a mouthpiece. And then on the right side here, I just want to introduce a couple of other ones that are good to know of just to have culturally informed practice as well. So in the top right, there's an image of a kretek, which originates in Indonesia, and it's 90% of the market there. What they have in Indonesia is these cigarettes that include a combination of not just the tobacco leaf that you can see shredded up in that picture, but also a combination of other things like cloves and clove oil and other additives. And then in the image below, that's a picture of beedies, which are essentially mainly used in India and some other Southeast Asian countries. And they're these small, thin, hand-rolled cigarettes, which also contain tobacco leaf, but also some other things that, like a dried tendu or timburni leaf, which are plants native to those areas. And you can also get things like dried sweet fruit and flavours like chocolate and cherry and mango in those as well. The reason I bring these up is because it's important to recognise that people from culturally and linguistically diverse backgrounds might use tobacco products in other ways. And if you're seeing an Indonesian group, or if you're seeing an Indian or Southeast Asian group, then you might find that some people will use kreteks or these beedies, and these have higher concentrations of nicotine, tar and carbon monoxide in them than other standard cigarettes, as you can see in that top left picture when the CDC looked into that. Then on the right side, you've also got loose chewing tobacco, which is sold in the States in some places. And then in the bottom right, just in that little picture with the three smaller images, there's snuff and there's snooze, which is seen in some European countries as a smokeless tobacco product. And then on the final image in the bottom right there, that's a heated tobacco product, which some of the big tobacco companies have developed more recently. So if we go to looking at how tobacco is prepared differently, depending on how it's consumed, that chewing tobacco, it's those shredded or twisted tobacco leaves, which, as the name says, people chew on. And then in snuff, that's that finely ground powder of tobacco leaves you can see in that small round canister picture that often is packed into tea bag-like pouches in the right side of that row there, which gets stuck between your gum and your mouth and just sits in there to absorb, which is a way that some people in countries like Sweden will use tobacco products. Another one that I bring up just to, again, have a cultural lens on things is bush tobacco, which is also referred to as patchouli. And that's a native Australian tobacco plant, which is found in places like Queensland, the Central Desert region of the Northern Territory and Western Australia. And what we see in these areas is that our Indigenous communities might use leaves and stems from these sorts of plants, dry them out, and then mix them with ash. So in that image at the top right, you can see a container containing white ash that can be produced from a range of wood that's burned, typically things like acacia. And then what you'll see there is that the stems and leaves have been ground up into that green slurry looking mix with ash mixed through it, and that's mixed with saliva. That all then gets molded together into a little quid, like you can see in that bottom picture there with the purple background. And that little quid gets chewed and held in the mouth for a long period of time, or it gets tucked behind the ear where it can also absorb transdermally, or you can take it out and then chew it at a later stage. The bush tobacco or patchouli has a significant social and cultural role in connecting Aboriginal people to each other, their land, their communities. It's often bought and sold, but more frequently it's gifted as a sign of being loved. So we also have to recognise that there are cultural implications of patchouli use as well. Interestingly, patchouli also has some hallucinogenic properties. It's thought to cause enhanced intense dreams. And it if you had a wild adult cow eat a few mouthfuls of the leaves, it would actually kill a cow. So it's a significant plant. Then if we go on to nicotine, again, more specifically, so what happens when you consume nicotine is that nicotine and other compounds are suspended in the smoke tars, which you inhale, and they get quickly absorbed in the lungs, mouth, nose, skin, stomach, and intestines. And when you smoke tobacco, those nicotine elements get to peak blood level concentration within 5 minutes, so very reinforcing. So if we look at that picture on the right, which summarizes the pharmacokinetics, you can see in that image number 1 there, you've got a nicotinic receptor, which is closed. You can see in the little yellow kind of tooth-looking image that it's closed at the bottom. In the presence of nicotine, that nicotinic acetylcholine receptor will open, and that will cause the brain signaling messages that you can see in that broader image, which causes the dopamine release and so forth. The important thing, though, is that with long-term smoking, you get increased craving, and you can get more receptors being formed as well from that long-term exposure to nicotine. So we can understand from this image why nicotine might be so reinforcing, because you get those peak blood level concentrations within 5 minutes and that dopaminergic release and the like. And then with all that continued action, that you might get a lift in the number of nicotine receptors as well. So another thing to note about nicotine is that people metabolize nicotine in the liver via the liver enzyme P450 CYP206, and we can do that differently due to things like genetic differences, and some people can be fast metabolizers as well. Importantly, smoking also produces these polycyclic aromatic hydrocarbons, which affect how the liver handles other substances, because it induces these other enzymes like CYP1A2 and CYP2B6, which normally help break down things, amongst others. And in that way, by inducing these enzymes and causing them to act harder in a way, the smoking through these polycyclic aromatic hydrocarbons can accelerate metabolism of other drugs that we might encounter people needing to use or using. So, for example, people who smoke tend to require up to 4 times as much caffeine as non-smokers to achieve the same plasma caffeine concentration. So there's a couple of studies that have been published now on how people who smoke are likely to drink more coffee as well. Insulin is affected by smoking. So if people stop smoking, then their insulin sensitivity is improved. So this is important, for example, if you want to optimize diabetic care and get the most out of the insulin that you're administered, then smoking will affect that. And some medications can also be impacted by these polycyclic aromatic hydrocarbons that come in the tobacco smoke. So this is a really nice summary sheet and table that's been put together by New South Wales Health that shows the broad range of drugs whose metabolism are affected by smoking cessation. And it's a really broad list. So you can see that benzodiazepines, beta blockers, caffeine and alcohol, chlorpromazine, or Lactol as it's sometimes known, some anticoagulation drugs like clopidogrel, clozapine, a whole bunch of other antipsychotics there, like olanzapine and haloperidol, warfarin, methadone. All these things can be impacted by smoking. So it's not just the smoking itself that we worry about having health implications. It's also the nature of how it affects metabolism of other drugs in the body too that people might be taking. So if we take a broad look at the prevalence of smoking in Australia. So how common is this? Should we be concerned? The good news is that fewer Australians are smoking tobacco. So if you look at that lighter blue line at the bottom there, you can see that it's decreased over time. So from 1991 in that graph to 2019, it's been slowly trending downwards to now in 2019, just 11% of Australians smoking tobacco daily. So it's down from 12.2% in 2016 and 24% in 1991, for example. When the Australian Institute of Health and Welfare broke down those stats, the reason for that trend is largely because our younger generations aren't taking up smoking. But the other good news there is that in 2019, a smoker on average would smoke about 13 cigarettes a day, which is also down from 16 cigarettes a day in 2010. The interesting thing to note is that smoking rates increase with socioeconomic disadvantage, though. So even though we're seeing less people smoke overall, it's a substance use that disproportionately affects people who already are disadvantaged. And then if we go into tobacco forms that are smoked in Australia, the vast majority is those manufactured tailored cigarettes. So 84% of smokers in the last 12 months in 2019 would have smoked that form. That's followed by your roll your own cigarettes or rollies. So 45% smoked rollies, and that's interestingly up from 36% in 2016. And that could be due to a whole number of things like cost, for example. A combination of manufactured cigarettes and tailors and rollies are smoked by people. So about a third of smokers will smoke the two. And then 14% will smoke the rollies exclusively. So they won't smoke those other forms. And then looking at e-cigarettes, 11.3% in the 2019 data said that they had ever used an e-cigarette, which has increased from 8.8% in 2016. And if you broke down that data again, the rise was predominantly in young adults. So we know that the use of e-cigarettes is increasing, and we know that there's some young adult uptake there. And the rest of the image just shows the other forms that can be smoked, like cigarillos and cigars and the like. So going into e-cigarette use in Australia a bit more, as I mentioned earlier, it's increasing. So in terms of existing traditional smokers, it's gone up from 31 to 39% that have used ever in their lifetime, with current use going up from 9.7% from 4.4%, sorry. The uptake has also increased in non-smokers. So previously it was about 4.9%, that's gone up to 6.9%. And then lifetime use of e-cigarettes has also gone up from 0.6% to 1.4%. So it's something that we should keep an eye on because it's there. If we go to the burden of smoking now, I'll start off by going into the economic cost. And Robert Tate and his colleagues at the National Drug Research Institute at Curtin University in WA did a really great analysis of this. And they looked at the 2015-2016 year data. So in 1 year, the cost of tobacco to smokers was 5.5 billion. So that's just the cost that people are spending on smoking. But then if we look at the tangible and intangible costs, the cost for healthcare just alone is $6.8 billion, which is a huge amount. And if you break that down, it can include costs like residential care for people experiencing health issues as a result of smoking, costing $420 million. The cost of your inpatient hospital treatment costing $1.5 billion, and so on. Other costs that accumulate from tobacco smoking include things like premature death, workplace costs because people might not be able to engage in occupations as well as they previously could, and absence leave and the like. Smoking fire damage actually contributes quite a cost as well, and litter removal costs $73 million to Australia a year too. And then if we look at intangible costs, so things like the cost of smoking attributable to just ill health and burden of that, and the cost of premature death and loss of labour workforces and having a person around, that amounts to a total of 117.7 billion. So if we add all these costs up, the total cost of smoking in Australia is $136.9 billion a year, which is a shocking amount. And within that, the cost to healthcare alone is approaching 7 billion. And this is 2015, 2016 data. And to put that in perspective, the COVID vaccine rollout, for example, cost $8 billion. So we're saying that we're spending around $7 billion a year on tobacco for healthcare. And then just overall looking at these total costs, we're spending 137 billion nearly on tobacco smoking. So these are extraordinary numbers and a really high economic burden to people smoking and also to taxpayers. If we look at health burdens then, so in 2017 globally, more than 8 million deaths were attributable to tobacco use. More than 7 million of them were for deaths caused by direct tobacco use, so people who smoke tobacco. And then more than 1 million were also caused by exposure to secondhand smoke, so passive smoking. If we look at Australia, in Australia, tobacco contributes to more drug-related deaths than alcohol and illicit drug use combined, and it's the leading cause of preventable disease and death in Australia. The annual estimate is that about 20,500 Australians will die a year from smoking, which is 13% of all the deaths we get every single year. And in terms of burden of disease, so we're looking at morbidity, not just mortality here, it was responsible for 8.6% of the total burden of disease in Australia in 2018 alone. If we look at the individual level, so a person who smokes 10 cigarettes a day has double the risk of dying prematurely. If they smoke 25 or more cigarettes a day, their risk of dying prematurely bounces up to 4 to 5-fold. And if we take all this together, a lifelong smoker loses on average 10 years of life. So a person who smokes throughout their life will on average die 10 years earlier than someone who doesn't smoke, which is a really confronting statistic and probably not one that most of our people who smoke are aware of, that they're essentially putting the clock on their life 10 years down. And then if we look at the burden of tobacco smoking, it's the biggest risk factor of concern. So if we start off by looking at the 2015 data in this table here, you can see that tobacco use really is at the top of the list in terms of its burden as a risk factor, and that's above things that we would normally consider risks like high blood pressure, being overweight and obese, physical inactivity, alcohol use, poor diet, high cholesterol. It is by far at the top. And in 2018, the same data was repeated. So it is still the leading contributor to fatal burden. And it essentially contributed to a huge amount of our disease and injury. So if we go to the health impacts of tobacco smoking more specifically, what's important to keep in mind is that it affects people at all stages and across all forms of exposure too. So harms from tobacco can begin before birth for a fetus in utero. So the perinatal adverse outcomes that we've found to be associated with mothers who are smoking whilst pregnant can include things like ectopic pregnancy, low birth weight infants, preterm delivery, stillbirth. This is not an exhaustive list, but this is some of the examples that we see. If you're a passive smoker, so if you get exposed to secondhand smoke, we know that that has been associated with things like cancer, respiratory cardiovascular diseases, and adverse effects on our health in other ways, for example, asthma and the like. And then this image on the right is an image that puts together what the US Surgeon General has collated from 50 years of tobacco research data in 2014. These are essentially the diseases, illnesses that have been associated with tobacco use through a really comprehensive investigation of temporality, significance of association, repeatability, and the like. And the letters in red, or the words in red, I should say, are the ones that have more recently been identified as a health impact of tobacco smoking. So that's important to acknowledge that we're still learning and we're still identifying potential health complications arising from tobacco smoking. And what's really striking in this image of a human body is that the effects are widespread. There's essentially no system in our body that can't be impacted by tobacco smoking in some way. Let's go into Aod populations now. So if we look at clients we see at Aod services, tobacco smoking is really, really common. A recent international systemic review that looked at this estimated that the prevalence of smoking in people seeking Aod services sits around 84%. The people who smoke in Aod treatment tend to have a heavier level of dependence as well. They tend to smoke more cigarettes a day. They tend to smoke for longer durations than smokers from the general population who don't present for Aod treatment. And because they smoke for longer, because they smoke more, the risk is that people who receive Aod treatment who smoke are likely to be more vulnerable to the negative health consequences of smoking and therefore more likely to die prematurely of tobacco-related diseases. And we know now that they're more likely to experience morbidity and mortality from their tobacco use than alcohol or illicit drug-related causes. And then there was this US study, which was an 11-year cohort study of 845 people who were previously in substance use disorder treatment. And they found that when they followed them up to the time of death, 51% of the deaths in that group were due to tobacco-related causes, which is twice that expected in the general population, which is a horrible thing to reflect on, that people who've come to us for substance use treatment might still go on to die from their tobacco use, and that missed opportunity to manage that when they were engaging with Aod services already. So this is quite a striking image, and this is again from the Australian Institute of Health and Welfare. So they surveyed the National Drug Strategy Household Survey participants on what they thought about tobacco, and the questions were, do you think it causes death? Do you think it's a drug that's the biggest concern in the community? And what you can see in this graph is that most people in the general population don't think that tobacco causes the most deaths, and they don't think it's the drug that causes the most concern. On a granular level, the data was typically that people thought methamphetamine and the like were the more dangerous, sinister drugs, but it's actually tobacco. And essentially what this graph represents is declining health literacy around the risk and impact of tobacco use, which we need to course correct. And then if we look at barriers to smoking cessation, so why people might not choose to seek help for their smoking, Laura Twyman and Billy Manevsky and a whole bunch of other researchers from the University of Newcastle in New South Wales did a really comprehensive systematic review of 65 papers that have been published in the literature around smoking cessation barriers. And it was a really representative systematic review because if you look at the breakdown on the left there, the papers included low socioeconomic groups, they looked at Indigenous groups, they looked at people with mental illness, they looked at homeless groups, prisoners, at-risk youth, and so on. So these are realistically people that we see. And barriers that came up that are concerning and that are definitely correctable were people saying that they don't have access to resources to quit, that there was a lack of support from health professionals, that they had low confidence, low motivation, that they were worried about having alternate means to cope with stress and mood, and that they had beliefs that smoking would help their mental health and help their cognition, things like low health-related knowledge, inaccurate beliefs around cessation treatments and risk of harm, and other substance use that needed help being managed as well were also identified as barriers. So this is very much in our wheelhouse as Aod service providers. These are all things that we can help to facilitate psychoeducation for and linkages for. So it's really quite striking that kind of half the barriers here are things that we could address. So in this next slide, I just want to pause a bit and see if everyone wants to reflect or think about what answers come to mind when you look at these particular questions or common myths that might be around. So a common thing that comes up as a challenge to why people might not want to approach smoking cessation advice or help might be because there's a worry that it might compromise treatment goals for other substances, that it's too much to try to do tobacco and say cannabis at the one time. So I'm just going to focus on the one thing. And if I try to do too much, then I won't be able to manage the cannabis use properly, for example. Interestingly, that's not necessarily true. What the researchers found is that smoking cessation efforts concurrent with other addiction treatment are sometimes associated with a 25% increase in long-term abstinence from other drugs. And it kind of makes sense in a way, because if you think about how substance use can be coupled, for example, if you tend to smoke whilst you're drinking alcohol, etc., managing the holistic picture of what's going on and the multiple addictions can have flow-on benefits for a client. Another thing that can come up is that tobacco dependence is a lower treatment priority than addiction to other substances, that we should treat the methamphetamine first, the cocaine first, et cetera, et cetera. That's false. We've identified from what's been presented before that it's really cigarette smoking that's the biggest culprit for morbidity and mortality in our treatment groups. It contributes to mortality above and beyond drugs like methamphetamine and the like, so it should be our core business. Another one that can come up is that 19% of smokers will never seek to cease smoking. So it's low yield to try to approach people who might not want to cease smoking, for example. That's false. That's a number I made up. It's actually 8% of people that report being happy to continue smoking with no intention of ever quitting. So it's a small number of people who say that they aren't interested in seeking help managing their smoking at all. And I just put that up there because sometimes people think that it's more than that amount who don't actually want help for their smoking. Another thing that's been a concern, particularly when health services went no smoking, was whether aggression towards staff would increase if tobacco smoking was banned, and therefore also if aggression towards staff will increase if we try to address tobacco smoking. There's now good literature on that. So total ban smoking policies haven't been significantly associated with increased client aggression or other aversive outcomes. And generally speaking, a smoke-free health service has a culture that's more favourable regarding smoking cessation care. And then this one. So does reducing the number of cigarettes smoked constitute a good safety harm reduction mechanism? That not ready to stop, so maybe I should cut down instead mentality. Interestingly, that's also not something that's been borne out in the literature. There's some literature that suggests that people who cut down the number of cigarettes they smoke each day actually undermine that best intention by compensating. So what you get is that when people have cut down a number of cigarettes they smoke, what they do is they adjust the way they smoke to get more nicotine out. So they might take deeper, longer breaths. So the cutting down number amount doesn't actually translate into harm reduction, because rather than taking shorter, sharper breaths, people might take those deeper, longer breaths and then effectively still get the same amount of exposure that they were getting before. Looking at clinician barriers to smoking cessation now. So clinicians might not engage clients in smoking cessation interventions for a number of reasons. And the ones that have consistently come up in the literature are things like lack of organisational support, lack of systems to identify smokers like screening practices, perceived patient objection if they approach a person about their smoking, perceived inability to change practices, so that hopeless, helpless mentality of they're not going to want my help anyway. Perceived lack of efficacy of interventions that are available for smoking help, lack of training and resources for follow-up, lack of reimbursement to offer smoking cessation interventions, their own smoking status. So interestingly, in the literature, we found that clinicians who smoke themselves are less likely to offer smoking cessation intervention to people than clinicians who are non-smokers. And also the belief that smoking will worsen mental illness, when in fact smoking cessation has been associated with improvement in mood for people. Flipping it though, factors which are positively associated with providing smoking cessation intervention and counselling include when people believe that it's part of your role as a clinician to offer smoking cessation advice, if you're confident in providing counselling and advice about smoking cessation, if you have knowledge of smoking cessation resources that are available in your local area or community, and the patient-centeredness of the organisation as well also lends really nicely to clinicians offering smoking cessation care. The College of General Practitioners also published a very similar sort of table, and what's interesting in their table is that they looked at practices, but then they also looked at what was borne out in the evidence. So interestingly, there were a couple of times where clinicians thought that they were doing things like, I have counselled all my patients who smoke, or I routinely refer patients for smoking cessation assistance, but that doesn't always bear out. So we know that only 45 to 71% of people who smoke are actually ever counselled around their smoking, and referrals to Quitline are really low. They only sit at about 10-25%, which is a shame because you've got this great service that's there to use but is being underutilised. So the summary of all this really is that health professionals often underutilise opportunities to provide cessation advice to smokers. These are sliding door moments, which could be really helpful if we address better. Interventions delivered by healthcare and social service providers can increase smoking cessation amongst service users, and 92% of people would consider managing their smoking across their lifetime. So it's a big group of people that you could potentially help out there. Even brief, simple advice about managing smoking increases the chance of successful cessation. And if you provide an intervention that has more than one component of the 5 A's brief intervention framework, you increase the chance of having quit rates. And the 5 A's, just to summarise and go through really briefly, it's really straightforward. It's ask about whether people use tobacco as the first A, advise people around what might be good for their health for their tobacco as the second A, so that it'd be good to get some help managing that. Assess their readiness to make a quit attempt or engage with smoking management, assist with a quit attempt or referral on for treatment and support, and then arrange that follow-up care as well. So ask, advise, assess, assist, arrange. If you do 2 or more of those things, then it really increases the chance of a person having a good go at managing their smoking. So, role of clinicians, what can we do on the front line, I guess? If you refer a person on to special services that address these common barriers to intervention, particularly time constraints, for example, the special service that comes to mind here being Quitline, you can really help someone out, because we find that proactive referral, so warm hands referrals where you're helping the person to bridge to that other service, leads to substantially higher rates of utilisation than just the generic provision of, we recommend you call Quitline and here's the number and you can go away and do it. If you assist the person to actually make that linkage, they have a much better chance of linking in. Quitline has this really straightforward, simple form to help you do that. So if you go to this website on the top right there, this is what the form looks like. And I put that up just to demonstrate how simple it is and that you could really just fill it in 30 seconds. All you need to do is put the patient's details in, their contact number, whether they prefer to be called in the morning, evening, so on. Hit the OK button, and then someone from Quitline will call the client up to talk through smoking cessation options. So this really helps to address that barrier of clients not knowing where to go, not thinking that there's help available, the barriers of health professionals saying that they might not have the time or the knowledge to be able to provide these interventions to people. There is a special service around that you can utilise and that you can refer people to, and you can get that referral sorted as quickly as 30 seconds using this referral form, and it doesn't cost the client anything either, or you. In terms of smoking cessation interests, so we looked at that broader literature that said only 8% aren't ever interested in managing their smoking. But if we look at the narrative of smokers' journeys to trying to quit, what we found that in 2019, 3 in 10 smokers had tried to quit before, but they weren't successful, unfortunately. 2 in 10 have been able to quit for more than a month, which is great. 4 in 10 have been able to reduce the amount of tobacco smoked in a day in the previous 12 months. And the methods that people are typically using are going cold turkey, that's 23%. Some have discussed smoking and health at home and tried to change their practices there. Only 16.8% have ever used nicotine replacement therapy, and only 10.2% have ever asked a medical practitioner for help to quit. So there's a lot of scope to enhance the access to options and the awareness of other options people have, because that really paints a picture of people not getting to maximise their options and have all the support that they could potentially get to assist with what's a really difficult addiction to quit. We also know that Almost 3 in 5 people said that cost was a really big motivating factor for them to quit or cut back their smoking. And that's increased over time as well, which is probably reflective of the increasing financial cost of smoking. Some nice, good news stories, which are always good to share with clients, is that quitting smoking helps to reduce your mortality with increasing time since when you last smoked being associated with greater reductions in risk. And there is also that awareness that for those who quit prior to age 45, their risk of premature death can come down to being quite similar to people who've never smoked. So that's always a good incentive for people to manage their smoking early too. So if we look at responses in Australia to manage smoking, evidence-based smoking cessation strategies that have been put into place and that are endorsed by our National Tobacco Strategy, which is currently being reviewed for its new iteration, include increasing the cost of tobacco. So we've seen the cost of packets of cigarettes go up over time. We now have non-smoking venues. We now have graphic warnings on our tobacco boxes. We have marketing campaigns to reduce demand and increase education about the risks of smoking. We restrict sale of tobacco products to minors. We now move tobacco products out of sight, so they're locked behind shutter doors in your supermarkets, for example. We encourage health professionals to advise, and we train health and welfare professionals to provide advice. And we also have some pharmacotherapies or medication supports that can be used to help manage smoking as well, which I'll go into in this next slide here. So the smoking cessation pharmacotherapies that we have around that probably aren't being offered to enough people and people probably aren't aware of enough include your nicotine replacement and then your medication approaches like Champix and bupropion. So essentially the most successful approach is to give a person behavioural support combined with one of these medications and follow up. The Champix you can see here is the most effective single form. It's the medication that you can see here, and you just go through the different sort of columns of the box in succession. Combination nicotine replacement is as effective as Champix and much more effective than if you just give one type of nicotine replacement. So whenever you're offering nicotine replacement therapy to someone, you should always give them a combination. And usually what I like to recommend is a patch. So you've got a baseline level of nicotine, and then they can build on that with a shorter acting form of nicotine when they would normally have a craving to go smoke. And the other types of nicotine replacement outside of the patches we've got include your lozenges, your gum, your inhalers, and your sprays. And what I would say with nicotine replacement therapy is that it's really important to educate people on how to use those properly as well, because sometimes they're not effective because people aren't actually using them properly. So common things that people do wrong with nicotine replacement therapy include with the lozenges sucking on them. Despite the fact that they're a lozenge, what you're actually meant to do is park them in the side of the cheek and just let them slowly release that way. A lot of people get stuck and think that it's like a lolly and that they should just suck on it, but they don't actually get the benefit out of a nicotine lozenge when you're using it that way. With the inhalers, a common error there is that people will breathe really deeply on the inhaler when what you actually need to do is treat it like a straw and do short, sharp sucks. So making sure that people use their nicotine replacement therapy properly will actually help them to get the adequate delivery of nicotine to help manage the craving, which they're trying to achieve with those medications. And then Champix, not Champix, then Zyban or bupropion is the other medication that's around, which is generally given if people can't tolerate things like Champix or combination NRT, but is not as effective as Champix in the literature as a medication support. Which brings me now to vaping. And I want to focus on this a bit because there's been a lot of change in the vaping space in the last year. So when I say nicotine vaping, I'm referring to things like electronic cigarettes, e-cigarettes, e-cigs, electronic nicotine delivery systems, personal vaporizers, vapes, pens. There's lots of names, but essentially they're nicotine vaping devices, and nicotine vaping involves use of nicotine vaping products that deliver nicotine and or other chemicals mixed in with that via an aerosol vapor that the person inhales. So if we look at how people vape, you first got to have a nicotine vaping product, which is the thing you put in the vaping device, and that can be your vape liquids, your e-liquids, your juice, as people might call it. And then in terms of the devices themselves, they can fall into two broad categories. So we either have mouth-to-lung devices or direct-to-lung devices, which I'll go into further now. So mouth-to-lung essentially is the way that people inhale the vapor. So you hold it in your mouth first when you suck it in, you let it sit there, and then you breathe it into your lungs from there, and then you breathe it out. So it's that breathe into mouth, breathe down back to lungs, and then you breathe it out. Whereas direct to lung is a deeper direct inhale, a bit like an asthma inhaler. And the way that you get mouth to lung or direct to lung is based on the device that you're using too. So our pens and pods typically have that mouth to lung option, which is closest to how you smoke a cigarette. And then direct to lung typically is those bigger devices like the tanks and mods. The nature of vaping devices has really changed over time. The first e-cigarette was actually made in the 1960s by an American inventor, but the modern e-cigarette was invented by a Chinese pharmacist back in about 2003 when he wanted his dad to stop smoking. The first generation of these vaping devices was that one that looked like a bit of an e-cigarette in that image there. They can't be refilled. They're cheap to produce. They're often disposable, and first generation, they had fairly inefficient nicotine delivery. Second generation vaping devices were these pre-filled or refillable e-cigarettes. They could be modified so that you could change things like the temperature and the coil, and people sometimes want to change the temperature so that you can control the burn and maybe get a bit more nicotine out of what's going on. And then your third and fourth generations there, they can again be a bit more modified. And your fourth generation, they use more of a salt form of nicotine than your original nicotine liquid form, which allows you to use high concentration nicotine than the liquid does. I'll go into that a bit more too. So essentially, in terms of nicotine products that go into these vaping devices, people will typically use either Freebase nicotine liquid or nicotine salts. Freebase nicotine is nicotine in its purest form. That's the first one that came out. Marlboro actually used to use nicotine liquid to bulk up the nicotine in their cigarettes, which is a cheeky way to get people more addicted. But essentially with the Freebase nicotine liquid, you get lower concentrations of, say, 20 milligrams per mil or less. They're cheaper. They're a little bit more irritating on the throat, and people tend to have to take smaller puffs more often. And the nicotine liquid usually contains a mix of propylene glycol or vegetable glycerin, as well as other additives like flavorings. And the propylene glycol and the vegetable glycerin are there because they help to carry the flavors and nicotine. The ratio or mix of the PG and the VG depend on what you want to get out of the liquid. So if you've got higher propylene glycol in it, then you'll get a stronger throat hit. Whereas if you have a higher vegetable glycerin amount, then that's softer on the throat and you can get bigger clouds. So essentially from this, you can appreciate that people who want to modify their experience of nicotine vaping will be quite particular about the ingredients in their nicotine liquid and the ratios of, say, your PG versus your VG, because that will alter things like throat hit, cloud formation and the like. What we've seen over time now is the emergence of nicotine salts. They really burst in popularity with the Juul device in the States. And essentially what nicotine salts are is they've added benzoic acid to your Freebase nicotine liquid, which is a natural chemical that occurs in things like berries, but it lowers the pH of the mix, which makes it a bit more neutral. So it can be a bit softer then to feel because it's not an irritating pH level. And then it also changed the chemical composition so that it can carry high concentrations as well. So typically we find overall that if people want a lower concentration of nicotine, they might use things like Freebase nicotine liquid. And if you want a high concentration, then you probably want to go to the salt end. And if we look at this image on the right, this graph here, the very top line is what a traditional cigarette looks like in terms of its nicotine release. The four curves below are for salts. So you can see that they're very high up and they're quite close to what a traditional cigarette would achieve. And then the very bottom one is an example of Freebase nicotine liquid curve. So that's just graphically representing those concentration differences there. So if people are vaping, and if we now have medically developed vaping devices as well, when might we recommend or consider using nicotine vaping as a harm reduction, smoking cessation strategies? In Australia, our practice now, and these are recommendations which are endorsed by colleges like the College of Psychiatrists, the College of General Practitioners, they're not a first-line recommendation. The first-line recommendation is still very much for people to try to manage their smoking through things like quit-line support, to get that adjunctive counselling, through pharmacotherapies like your nicotine replacement, like your Zyban, like your Champix. But we know that all those treatments don't work for everyone, or some people might try those options and not have success with them. So the next line option in some cases might be nicotine vaping. We would recommend it for people who are over the age of 18 who have tried those first-line therapies and not had success. We also would consider these when people are agreeing to use this in isolation. So there's not much point in recommending nicotine vaping if people are still smoking traditional cigarettes. It's not for dual use. And you might also recommend it if people are vaping anyway, because then at least you can get some medical oversight and quality control over the vaping that they're using. Because we know that there are a lot of people out there who have already gone to nicotine vaping of their own volition because it was only made only legal for prescription from October last year, so fairly recently. The reason why we have these precautions is because we know that vaping isn't risk-free, but it is still a way to quit cigarettes by getting nicotine without exposure to the other cigarette smoking harm. So we talked earlier about the risk of things like tar, carbon monoxide, or those other carcinogenic ingredients, the risk from those other components of tobacco smoke is not to be unacknowledged. And in that way, we would consider on a risk continuum of nicotine products, your combustible tobacco to really sit at the top in terms of being most likely to harm. Medicinal nicotine options like nicotine replacement therapies sitting at the least likely to harm. And in the middle, we've got electronic cigarettes and smokeless tobacco. In Australia, though, we don't have smokeless tobacco like snus and snuff, which I introduced earlier in that first image of tobacco products. They're banned and illegal in Australia, whereas other countries like Europe have those options. So it's important to recognise that when we talk about vaping, and if we ever medically recommend it, it's not because we don't want to abandon the overall goal of people ceasing their smoking. It's just a step that can be used for harm reduction to move them to a position of safety as you're helping a person along in their motivation and stage of change and acceptance of other interventions that can help them to stop. In terms of the evidence around vaping, because this has been a really contentious issue, the Cochrane database of systematic reviews has done a heap of work in this space over the years, and their most recent systematic review in September 2021 identified 61 RCT studies which they examined, which looked at e-cigarette use in a whole variety of countries, mostly the States, but also a couple in the UK and Italy. And what they found overall from these 61 randomized control trials is that people who use nicotine e-cigarettes probably stop smoking for at least 6 months than if they use that, nicotine replacement therapy. So there's a group of people who might not do as well with nicotine replacement therapy or nicotine-free e-cigarettes than people who use nicotine e-cigarettes. We can also see from this that for every 100 people who use nicotine e-cigarettes to stop, 9 to 14 might successfully stop. And that's compared with only 6 out of 100 people using nicotine replacement therapy, 7 of 100 using nicotine-free e-cigarettes, so your non-nicotine liquids, and 4 of 100 people having no support or behavioural support. And the unwanted effects associated with vaping largely include things like throat or mouth irritation, headache, cough, feeling sick, which isn't surprising given the nature of what the vaping devices do and the kind of irritant nature that those juices and salts can have as well. So I've alluded to this before, but the legislation in Australia now is that as of 1st of October last year, to use vaping devices, you're meant to have a prescription to legally access them. And the other things that the TGA has done is that when they have set parameters around how to prescribe nicotine, They also require some quality controls around nicotine liquids and salts. So in ingredient listing, there has to be a capped max concentration. The liquids and the salts have to have a warning label. They have to have child-resistant packaging. They have to contain fewer additives, and in particular, avoid additives that are known to cause harms like popcorn flavour, which has been found to have popcorn lung or bronchiolitis obliterans impacts on people. The cost of prescription nicotine devices and products generally equates to about $50 a week. So it's pretty much similar to or cheaper than smoking in most cases. And it's an opt-in system for prescribing. So not all medical practitioners can prescribe nicotine vaping now. You have to sign up to become an authorised prescriber. And there are some regulations around reporting back to TGA how many patients you're prescribing for over a period and so forth. So there is this publicly available list where prescribers have agreed to have their details put online of who is around that is currently accepting people for nicotine vaping products, for example, or has been prescribing nicotine vaping. So to wrap up this talk, I just wanted to cover a couple of harm reduction vaping safety tips, because essentially people are vaping out there. There's also this legal framework to facilitate vaping now as an additional option on top of our other options like nicotine replacement, like Champix, like Zyban, to help people manage their smoking, knowing that it's worth a go, because if we watch people smoke throughout their lifetimes, then we're watching them reduce their lifespan by 10 years, as well as increase their risk of all the other morbidity risks and the like. So if you've got someone who's gotten to that point of using vaping to try to manage their smoking, some really good and practical harm reduction advice you can give them is that you shouldn't dual use. So if you're vaping, the harm reduction benefits of vaping aren't going to exist if you're smoking traditional cigarettes or rollies at the same time. So stick with the one. Always combine with psychosocial interventions for a better chance of success. There's no silver bullet medication out there. So it's always good to put your eggs in multiple baskets, get the psychosocial intervention alongside the pharmacological intervention. With e-liquids and salts, store them at room temperature, and always look for the products that have as minimal additives as possible. And you also want the regulated nicotine with the child protective packaging to reduce the risk of kids and the like getting into them and accidentally swallowing them, because if you swallow the liquid, it can be quite dangerous. So 5 milligrams per kilogram is a toxic dose, and kids can sometimes be a bit curious about bottles and the like. So that's an advantage of the TGA framework, that you're going to have that tamper-proof packaging for kids, and that things are going to be clearly labelled. The usual process with any other medication of concern: always store them high, always store them away from kids, make sure that it's clearly labelled. And if you access the legal supply, those protections will already be in place because it's a pharmaceutically regulated product. Other things that are good to tell people is to be mindful of contact reactions, because nicotine liquids, they can be quite irritating, particularly at that high concentration level to our skin, our mouth and eyes. So if you're using a refillable device, for example, where you're pouring in nicotine liquid and you accidentally spill a bit on your hand, you probably don't want to go touching your mouth or eyes, and you want to wash your hand as quickly as possible then, because it can be quite irritating on your skin. Another common sense thing that is probably still worth averting is that if you're using a vaping device that's got a rechargeable battery, you always want to use the correct charger and don't leave it unattended while charging. There have been some international reports of devices exploding, and if you're buying an unregulated device that maybe doesn't have the best quality control and might not have the most quality interior, then that risk might be there. The other thing that you want to do is consider using vaping devices that have safety features like vent holes, so that the vaping device doesn't overheat. Again, this is an advantage of a regulated market. And also don't vape random stuff. So these devices are developed to have things like nicotine liquid in them. The danger of putting things like cannabis oil in there is that it's not what it's produced for, and that can have risks. There's a heating element in these things. So if you have a refillable, reusable device and you want to change the heating coil every 2 to 4 weeks so that that doesn't burn out, and usually what will happen is that the taste will become burnt and pretty acrid if people persist beyond that period anyway. And the common sense thing of it's not something that we recommend for youth yet, because it's also not legal to prescribe it for youth. And there's also sort of the risk that has been documented in some cases of it being potentially something that could increase uptake to smoking if youth vape as well. And the overall important message is that there's not evidence for long-term safety of vaping yet, and we're only really using it as a pathway to assist smoking cessation. So you always still want to review and maintain that conversation about, let's review where you're at with smoking. What's the next step we can take you to keep moving you to a position of safety and keep helping you on your overall quit journey as well. So we don't want people smoking or vaping long-term. And that brings me to the end of my talk. So thanks for listening. And we might open it up for questions now then, Annie. I'm conscious of time too, so we'll have probably a bit of time for some.
Hi. So I've collated questions, Vicky, and there are a lot of questions. So I want to apologise to people if we don't get to your we don't get to your questions, and I'm sort of grouping them. There were a lot of questions about vaping, but just quickly, there were two on smoking. And the first is, what are the implications of third-hand smoke?
Mm-hmm. So did you mean third-hand smoke as in tobacco smoke or?
Tobacco smoke.
Yeah, well, I mean, we went through this on a previous slide, but essentially there's still in terms of, for example, respiratory irritation. So people who have asthma, for example, might be a bit provoked if you're around environmental smoke. There's also the associations of chronic disease that have been documented when people are around secondhand smoke a lot as well. And that's really what's informed strategies like smoke-free environments, so not having smoking around a health facility, having venues have bans, encouraging people not to have their windows closed when they're smoking in a car, for example, because we know there's all those risks. So the risk of environmental smoke has been well established by this point. If the question was about vaping smoke, that's still an emerging space for literature, but of course you've got these chemicals that cause environmental risks, so it's probably best not to be around these sorts of smoke fumes anyway.
Yeah. What about, can you just quickly comment on the issue of obesity or diabetes being associated with quitting?
There's not an association I know of in terms of if a person's obese or overweight or is living with diabetes having more or less of a tendency to quit smoking. If you mean the slide where I brought up the overall risks, the smoking sat much higher on the table than things like weight and poor diet in terms of overall morbidity. So you've got multiple things there that cause risk to someone's life. So if someone's living with obesity or if they're living with diabetes and that is already an independent risk factor for morbidity and mortality, and you're smoking on top of that, they've got multiple reasons there to try to optimize their health.
So there's no evidence that people would put on more weight, for example, when they stop smoking.
Yeah, so I think there is this sort of broader discussion of whether, for example, when you quit smoking, people might comfort eat or things like that, I guess. It's if you look at the long-term picture though, stopping smoking is always going to improve your cardiovascular health and general health more than anything else will. So you're looking at those long-term gains overall rather than just the short-term disadvantage of people struggling in that short term, understandably, when they're going through a major change. So I would not be concerned about a person with chronic disease of any kind having a difficult path quitting smoking, because that's part of the course, and that's why we're here as clinicians to assist them with that, so it's a bit more comfortable and less confronting and less overwhelming. And it's about teaching them those other strategies to manage things as well, so that you're not going to compensatory behaviours like overeating or comfort eating, which aren't going to be good for your health either. That's our role as professionals, to help bridge that gap. It is a dangerous thought to have that it's going to worsen my health in other ways, because you're in that way minimising the overall risk that smoking is having to the person's life and the overall benefit that is going to be gained by helping them to manage that.
Okay. Um, uh, I think some of the questions you've already answered when you spoke about vaping, such as the notion that vaping is a good harm reduction strategy. What is the purpose of nicotine-free e-cigarettes?
Yeah. I think they're probably more of a way for companies who produce them to invite consumers into their market. We don't use non-nicotine vaping devices in a medical environment because there just is no evidence of any health benefit for them or purpose for them. The danger of those non-nicotine vaping devices is that they can appear as quite attractive, fun things to use, which can then potentially lead to the ramifications of people continuing their vaping or stepping up their vaping to other things. So they don't have a role in the health sphere. There's something around that we should be concerned about. And if you have someone who's using a non-nicotine containing vaping device, the harm reduction advice and the psychoeducation advice them around the risk of that still stands. So you're still exposing your lungs to a whole bunch of additives. What's in that is a mix of glycerols and other additives and heat, irritant, toxicant effects potentially to your respiratory symptoms, to your respiratory system, which would be good to avoid. There's not a medical purpose for that device. So it's potentially quite a nasty habit that you're developing there. So yeah, we don't use non-nicotine containing vaping devices in a pharmaceutical sense, but they are something that's around on the general market, which is being used. And even though they don't have the substance use disorder attachment to them because they don't have an addictive substance like nicotine in them, they're still a risky thing that if we opportunistically come across someone using, we should advise them of those risks.
Okay. Now we're going over time. Are you happy to answer a few more questions? Because I know that some people have to leave, but this is being recorded.
Yeah, I'm happy to answer.
Thank you. Should hospitals use vaping for those who refuse nicotine replacement therapy?
Good question. So we currently can't because they come under smoking products. So the legislation in Australia would be that we're currently not able to offer that because it just would be banned. The NHS has been considering this though, interestingly. So overseas in the UK, they have looked at whether there are devices that could be developed that would be safer or less concerning to use in a hospital environment because of the recognition that these can be a smoking cessation aid to some people. So currently in Australia, simple answer is no, we can't because it's not allowed in any case. But this is an area for research. This is an area for development that is being considered overseas in places like the NHS.
Great. What's the best assessment tool and treatment for vaping dependence?
I think in terms of assessment tool, there's not a specific tool that's around for vaping. If you're thinking about assessment tools, they're things like the assist and the comprehensive assessment to help guide question frameworks and the like.
Yeah.
If you want to assess for vaping, the simplest thing to do is to ask if a person is vaping and then to explore that in terms of how often they're using, the frequency, what they're putting in their vaping device, the nature of their vaping device, how they feel about it, have they ever tried to stop and so on. So there's not a specific tool that I'm aware of specifically to assist with assessment of vaping. And the second part of the question, Annie, I might just get you to repeat that.
I think that was it. But yeah, that was it for that question. Or assessment tool and treatment. Well, I suppose the treatment would be in line with other treatment modalities for tobacco dependence.
Yeah, so if you've got someone who's vaping, it's having that broad conversation of, okay, how did you come to that? And what would you like to see happen with your vaping? So if there's someone who, for example, moved from traditional tobacco smoking to an electronic vaping device, it might be that they did that as a way to move away from smoking. And then a really good opportunity there is that if they're finding that vaping device to help them, if it's an unregulated, illicitly obtained nicotine vaping device and nicotine products that they're putting in that, just letting them know that it's actually illegal now to use those and that they have an option of a legal pathway which has medical oversight, which has regulated products with more safety provisions and controls to reduce risk to them as well as other people, like pediatric exposure. And a lot of people don't actually know about that because this is fairly new. This only happened in October last year that this framework was rolled out. And in my own practice, I've seen quite a few people who were vaping already because it was available through the internet and is still available through the internet, unfortunately. But just having that conversation with them that there is that legal framework now for it with that medical oversight and that they don't have to do it on the dodgy has been quite useful for a lot of people to recognise as well. So, yeah, I would put that to them. And then some people who've gone to vaping as a way to try to manage their smoking might not have actually been aware that they have other options available to them, like the medications and nicotine replacement. So making sure that you do your due diligence of making sure that people are aware of everything that they have accessible, that they don't have to do it alone, that there's treatment and support there, and that a lot of this is subsidised by things like the PBS as well, and they just haven't had the opportunity to get it. It's really useful to let people know.
Okay, there's an acknowledgement of an outstanding presentation, a lot of really positive feedback. I don't think we're going to get through all the questions. For those using vaping as a form to help them quit, in your view, is MTL or DTL better?
Yeah, it's tricky because people will always have a preference as well, and you want to use a device that they're actually going to stick with if you're using it as a harm reduction measure. Mouth to lung is closest to a cigarette. So if people want to replicate their experience smoking a cigarette, mouth to lung is really the one that's going to match that the best, because it's that breathe into your mouth first and then breathe down to the lungs, rather than that really strong, sharp inhalation direct to lung that you think of when you're using things like your Ventolin puffers and the like. So for someone who's new to vaping and who's only been smoking cigarettes, I would probably recommend mouth to lung in that case, just because it's their regular practice in terms of inhalation technique. So you don't have to get over that learning curve of breathing differently. And it's also a bit more similar in terms of behavioural conditioning to what they already do.
Yeah. Would you use NRT if someone wanted to stop vaping and had tried but failed to quit?
Yeah, I think, there's always the option of those other smoking cessation options. So it's not that you always have to keep going downwards down the line. If people want to go back to a first line measure, then you can still offer them that. It's not that they miss their chance of those things. So I would always be happy to offer nicotine replacement to someone, yes. And in practice, we do, for example, when people come into detox minutes and they obviously can't vape, in those cases, they go to nicotine replacement therapy, because that is what we can provide in that environment. And sometimes people might even just quit the smoking from that environment because they've managed to detox off the tobacco at the same time with the NRT, and they want to have a go at seeing if they can go without vaping straight after detox. So you definitely can.
Great. And do you have any advice for people who buy illegally imported e-cigarettes?
Yeah. That harm reduction slide at the back, I think, is so important, that people know that you should be careful about refilling your nicotine liquid. Don't touch your eyes, don't touch your mouth. Be very careful about the chargers you use and where you put the charger. Like, don't put it on the windowsill in direct sunlight where it might overheat and explode. Making sure that you change the heating coil, because things in a device that you're blowing into and out of, they get a bit germy and they get a bit burnt out. So you've got to replace those parts, making sure that they know that there's a legal framework for them to get these things. There's lots that you could do in terms of harm reduction in that discussion for them. And I think that humanistic approach really helps too, because people don't feel like they're being judged on the fact that they're using vaping. It's that curiosity concern of, really glad you told me that. I might run you through your options with that now, because there's actually this sort of legal framework for vaping now. And if you're using those online market devices, then these are the things you want to be really careful of. And what support and assistance or questions do you have from this discussion that I can help you with ongoing?
Thank you. I think you've covered pretty much most of the territory of the questions that were being asked. And there's more comments coming in thanking you for the outstanding presentation. So it's been greatly appreciated by a lot of people. Some people asked about some of the literature, and I said that they're going to receive the slides, so they'll have the references.
Yeah, the recording will go up so you can refer back to slides definitely and pull them out. But yeah, thanks everyone for attending and for staying behind too. I know that this session has gone a little bit late.
It has. Thank you, Vicky, for the presentation. It's been wonderful and I've learnt a lot.
Great. And just a final plug for the evaluation survey too.
Yes.
The time to fill that in.
Yeah, please do. So everyone will receive a QR code for that. And it really helps us if you fill that out.